Fantastic. Let me just have a look and make sure people are making their way in.
Okay.
Seems the room's filling up, which is absolutely great.
Good.
Welcome, everybody. We'll just do a little bit of an introduction as we move through, and then we can obviously let people come into the session as they click on the links. Hi, everyone. Welcome to today's webinar. I'm Nathan from the European Pain Federation, and I'm joined, as you can see on your screen today, by two speakers who have kindly agreed to share their incredibly valuable opinions on the priorities in educating patients and healthcare professionals, but from the patient perspective. Excuse me. I'll give Joe and Chris a chance to introduce themselves in just a moment. We'll go for a few points about the webinar if you haven't been to one of these before. You can see that it's recorded. It's a live recorded Q&A session. You can see that you have the privilege of being able to ask the speakers today questions. There's a Q&A function just at the bottom of the video feed right now. Feel free to take a moment just to see if you can see that. And just to let you know, you can ask questions anonymously as well on there, so don't be shy. Get your questions across. It's a great opportunity to pick the brains of Chris and Joe to help obviously get a discussion going. We love passing questions on to them, so I'm sure they'd be really excited to hear, and we'll try and get through all the questions today as well, so feel free to put those in there. There's also a chat area for general discussion, so if you feel like that your comment might not be specifically a question, but perhaps it's a comment to something that we're mentioning, feel free to put it into the chat function as well. As I mentioned, really good opportunity, and I'll remind you guys sort of halfway through the session that you can submit questions and we'll go through. We've already got a couple of questions that we're going to go through anyway, but please feel free to add them just when you see fit. I think this topic is going to be really, really interesting. I've got a few questions myself, which is going to be great. But obviously, I encourage Chris and Joe to ask questions as well to each other, and we'll get a really valuable session for everybody here today. So to begin, maybe we can, as I mentioned, let the speakers introduce themselves, who they are, and perhaps a little bit about their background. So, Chris, hi, welcome. Thank you so much for spending time with us today.
Hi, Nathan. Thank you. I'm from the north of Scotland, very north of Scotland, where it's very cold today and wet, but that's kind of typical. I've lived with chronic pain since 1978, and I set up our charity really originally to help people get over the isolation of chronic pain, but I'm pleased to say it's grown and grown over the years. My pain is neuropathic in nature, although it's never actually been officially diagnosed as any one particular pain. There's always been rumor and speculation, but nothing actually specific, although it seems to be classed as fibromyalgia, oblique complex regional pain syndrome. But whatever the label is, it hurts. That's sort of my background. I worked for about 20 years in the Bank of Scotland, had to retire medically way back in 1995. So I've now been retired longer than I ever worked. But here we are.
It's a fantastic position to be in, I'm sure. Thank you so much, Chris.
Yeah.
Welcome in. Welcome in. And Joe, welcome in. How are you doing?
Yeah, very good. Thanks. Nice to see you again. Yeah, so my name is Joseph Parsons. I come from an academic background, so I did my PhD in breast cancer research, but I moved into the pain field, having lived with chronic back and neck pain for the past 11 and a half years. I'm now spinning many plates, wearing many hats. So I'm a trustee with AFSR, and taking kind of a research angle into the charity. I am the chief operating officer of a company called Paint, which is doing digital self-management for people with chronic pain. I'm a research associate at Teesside University, and I'm retraining as a physiotherapist to have a more direct impact in the day-to-day lives of people with pain.
Fantastic. Look at those hats. Brilliant. All fantastic hats. Great. So thank you so much, guys. Appreciate that. Hopefully that's given people a little bit of a more understanding of who you are and what value you can bring today. You mentioned there, Joe, affaire. Pronunciation might be right, it might be wrong, but you've mentioned these in your video sessions that are on the EFIC Academy platform. Chris, could you perhaps give us a little bit of an introduction about what that is, and give us an idea about how that's relevant to today?
We like to give people the chance to speak about pain and things from their home, because they're so isolated, especially up here, with the lack of infrastructure and things. People can't get about easily. So, being able to show them videos of discussions and things we have are really good. It gives them an opportunity to educate themselves when they want to. They don't have to turn up at some meeting or other, when it's stipulated. They can choose when the pain allows them to take things in, because anyone in chronic pain will know most of your life is spent battling the pain when your brain shuts down anyway, so you don't always take things in. So no, the opportunity to do things for EFIC has just been brilliant for us. It's been really good, and it gives people the opportunity to experience things they wouldn't normally do in the country here now. It's such a low level, problem's not the right word, but it's such a low level section in the National Health Service that there's really not much spoken about chronic pain. It's all other health conditions that are given a priority. So people have to find things for themselves.
Mm-hmm, mm-hmm. And developing that conversation and bringing people to the forefront and giving them a platform to discuss those types of things, right?
Yeah, I think you have to educate yourselves, really, unfortunately. And most people really don't have the resources to do that. So, being able to use video stuff and everything gives us the opportunity to go direct to their houses.
Mm-hmm, mm-hmm. Absolutely. Joe, anything you'd like to add to that one?
Yeah, I think in terms of giving a background as to what AFASER is doing in this front, we're kind of working in a kind of three-layered system at the minute. So AFASER began as an online group for people to be able to share their experience, to, as Chris said, to sort of overcome this isolation. And so there's still a big element of that within the group. There's opportunities for people to discuss with one another, and it's in a moderated setting. So Chris, over his decades of pain experience, has become an expert not only in the lived experience field, but also in the research. He's deeper in papers than I am, and that's meant to be what I do. So, so we have that element where there's a moderated community, so it's a safe place to share and discuss things. We have this kind of second layer where we're providing content and recommended sources, so we're ensuring people don't kind of dive down the WebMD rabbit hole, and we're trying to share resources as we come across them. But we've moved in the past year from just being an online community to trying to move more into in-person events as well for people who are capable of doing them. So that began with Chris organising monthly meetings. So people were meeting up in different places in the northeast Scotland to get together and kind of put names to faces. But we've been very fortunate to get funding from the Scottish Government from two different funding pots, the Section 10 funding and the Self-Management Fund. And we've been able to put together a social prescribing scheme. So we have GPs in the northeast of Scotland who are prescribing to their patients access to this scheme, and that gives them access to hydrotherapy, art therapy, walking groups, to allotments, to guided exercise classes online, to monthly meetings, to book clubs. It's kind of this really all-encompassing social element, because we've recognised not only online but in person there is a real lack of the social part of biopsychosocial.
Absolutely, and that's perhaps reiterated from a lot of clinicians and patients. This need for the social aspect. We're so heavily focused on the biological, of course, but the psychological and social, and I guess it's easier said than done. What you guys have done with AFASER is really remarkable. Creating these networks and this platform for patients to be able to discuss these types of things and access that type of sort of social aspect of the biopsychosocial care. it'd be interesting to see if you know other people have sort of similar things going, but what you have is it sounds really key and sounds really useful for people, you know.
It,
I
it,
mean, sorry, Chris, go ahead.
it all comes back to the name. I should perhaps explain to those of you who don't speak fluent Scots that aphasair means very sore, apha being very or awfully, and sair being sore. So that's where it comes from. And you know what people in this area, that is what they'd say in their everyday language. You know, how are you feeling today? Well, I'm aphasair. And that the name kind of stuck. And I think that's what got us a lot of attention, that it didn't come across as a group that was lecturing to you. You know, it wasn't a clinical group as such, and it's, with the exception of Joe, no one else is medically qualified in the group. You know, it's all chronic pain, it's all volunteers, but you know, I think sometimes clinicians, and I don't mean to insult anyone, but clinicians can put off ordinary people because the ordinary people don't understand their language, you know, the shorthand that they have. You know, I can be guilty of that now because I have, as Joe said, I've educated myself to quite a high degree. So I'm as guilty as anyone else of coming out with the jargon. But to the normal chronic pain sufferer who turns up at the clinician's door, you know, they're totally bewildered and they don't know what to say. And I think we've helped in some ways gently get them into discussing their own pain and things with each other. So, you know, our Facebook page is incredibly busy, and it really just shares experiences. We have absolutely no problem with someone moaning all the time. We encourage it for people just to vent and you know, to get a release there. And we find time and time again, you know, people will come up with suggestions on how to cope with a bad day, and people seem to relish it. They love it, and it's grown and grown and grown. I think we've now got over 750 members. I know we started with 80 something in the first year, so I'm pleased with the growth.
Mm-hmm, mm-hmm. And it kind of leads into the topic of, you know, what type of education can we provide clinicians or patients to help manage these types of things. And we've kind of took a step more broadly here and said, well, what environments do we need to have for this to be able to work? And it sounds like that's been a real focus of FSA. Would you, and perhaps to Joe, would you agree that people need to not only consider the types of education and the quality of the education that's being provided to patients, but perhaps the broader setting in which it is delivered?
Yeah, I think unfortunately we live in a sort of very paternalistic medical environment. So people expect treatment to be done to them. And so we've been deconditioned as a patient population from being engaged in our healthcare. So we don't think that it's our job to know about it because our doctor, our nurse, our physio is there to fix things. And so I think, unfortunately, we've reached a point where we're so sort of unknowledgeable about our own health, and that obviously doesn't go for everyone, but as a general populace, that we need to start trying to attack all angles with this education for patients. So there's the only time a lot of patients get access to sort of education about their pain and how to manage it is in that doctor's office, and usually it's in a GP's office. And the current average clinicians' medical training on pain in UK medical schools is 13 hours. And I know I'm preaching to the wrong choir because everyone at EFIC is probably far more trained than that. But I'm sure they can recognise that the GPs that we're seeing as patients on a day-to-day don't have those skills. And so they might be peddling outdated ideas. So a lot of them are still very much firmly set in the biomedical model, and they're talking about what injections we can have, what drugs we can have, without recognizing that that's not a viable way for the majority of people to manage their long-term health. So there needs to be better education from clinicians so that those people who don't engage outside of the doctor's office can begin to become educated. But I think we really need to start exploiting forms of media that people digest. So taking things like podcasts being extremely popular at the minute. So taking those opportunities to give people options to engage in content in a way that they feel comfortable. So if it's someone in of my age, they might be on TikTok for whatever reason, but we need to exploit every avenue we have available. So whether it's TikTok or Instagram for kind of younger generations, whether it's leaflets in the doctor's office for people who are regularly there, I think unfortunately we have to attack all the angles right now because our patients have become so dependent on their clinicians knowing everything and doing healthcare to them rather than with them.
Mm-hmm.
It's something I battle with daily. I don't particularly like Facebook, but yet that is where we live, really. But it is a way of getting to the majority of people. I am 65 now, nearly, and I'm certainly nowhere near Joe's age. So social media kind of leaves me cold sometimes, and I don't see the point in it. But it gets so much attention from people, and we have to go there. I think people are reluctant because, I mean, Joe's alluded to this before, but you get crazy ideas like, well, if you eat a cabbage every fourth moon and all this sort of thing, you'll be fine for the rest of your life. You can get all that sort of nonsense. So it's knowing where to go, and I hope with us in the picture, and others now are coming onto that picture, that we can give people sensible options of where to go and where to get their information. The Scottish Government here are trying to make a big difference in what they're doing, but it's slow going. But I think you always find that with governments, it's very slow going, but they are trying to find new ways to educate people. But it could take forever the way things are going, and then you have elections and governments change and blah blah blah. So unfortunately, it is up to people themselves, I think, to try and find the solutions. I mean, I thoroughly enjoy what we do, but boy, is it tiring at times, because there are so many questions, and the busier you get, as I was saying to Nathan Erdo, I can't get out of my head. I've already told you that last week. Why do I have to tell you again? But you do with people, because the pain isn't just physical, it affects you mentally as well. And you're so exhausted with it that you can't possibly take things in. So you've got to be repetitive. You've got to use every avenue you can find. And although we're not on TikTok, and I don't particularly see us getting on TikTok unless Joe wants to do it, but I'm not going to go down that route. I see the necessity in that sort of routes now. But what I'm pleased about recently is we've had such an influx of new members, and with our social prescribing scheme, they've found their voice too. So within the confines of Afasair, they've set up their own chats and things, which I must admit I seldom look at myself because I just don't have the time. But it's amazing the conversations that go on there, and people find it easier to speak to themselves, I think. As Joe said, GPs and things only have like sort of 10 minutes or so to discuss anything with you, and you just can't do it in that time. Whereas by using all these chat lines and things, then people will chat all hours of the night, and it's really helpful to them.
Mm-hmm, mm-hmm. So it's not, again, it's not just, and I think the discussion when we talk about education being provided to patients, the focus is usually on the quality. What are we teaching them? What topics are we covered? And I think there's, from a research perspective, there's a fair amount of research showing what we should be included in this type of thing. And I think the discussion is less towards, how often we should be providing that, and in what manageable ways can we support the self-management and the continuous delivery of education. It sounds like the social prescribing and everything that you guys are doing, you're creating that environment that's long-term, that people can use for long periods of time.
Yeah, I mean, that's absolutely what we're trying to do with the scheme. It just gives people that opportunity to share and discuss. But I do think that with trying to kind of branch out into these these different settings, and share this educational material. It can be quite challenging for us as a charity, because the materials that we want to share, as you say, the literature dictates that there should be stuff about pain education, there should be things about self-management, we should be talking about pacing, boom and bust, etc. But all of these resources are all over the web, and some of them are outdated, and some of them were brilliant in their time, and are now there's updated information. So it is a real challenge. So credit where it's due. As Chris was saying, the Scottish Government are working really hard on their chronic pain web pages to standardise the content themselves. So rather than saying useful links and have 40 links that a patient has to go and explore, and those websites are from 1999 and have been updated since and are very hard to navigate, they are trying to find a centralised place in which to use this. So if any patients end up viewing this recording at some point, can thoroughly recommend exploring that. It's not comprehensive yet, but it's definitely taking steps in the right direction.
Mm-hmm. Mm-hmm.
We had one of our self-management activities as part of the social prescribing scheme last Thursday was an art oblique craft therapy session. And you think, well, that's just doing something, and then the idea was it lets people distract from the pain. But what I found in conversation with people there is we started speaking about, it was actually about the benefits we're entitled to when you're in chronic pain. There's been changes here in the country where some of the social benefits are now devolved to the Scottish Government as opposed to Westminster. Don't need to get into the politics here, but the Scottish system is easier, is better in my opinion for the pain patients. And it was great because I was able to explain to people how easy it is for the new system, and they just didn't know this because no one really, the newspapers of the day or the mainstream media don't really push these issues at all. So, there we were doing craft therapy, painting and needle felting and things like this. But yet we were discussing issues that can help people too, financially as well as physically.
Mm-hmm. Absolutely. Some amazing points there, and taking it, across the broad spectrum and providing this type of thing for everybody for long-term management. I want to dive in just a little bit about specifics. So if there's any clinicians in here, or if there's any clinicians who are watching, what aspects of patient education, we've mentioned that there's some literature to support several elements, but obviously this is the patient perspective. We want to hear from people with lived experience of chronic pain. Was there or were there any things which were useful in terms of pain education that you might remember that you received, and were there things that were unuseful? Maybe paint a little bit of a picture about the education that you received when you were going through that process.
Well, you must remember I was going through this process in the 1980s. So in one word, absolutely nothing. Well, two words. So I learned absolutely nothing. It was recommended I be strapped up in a plaster jacket for 6 months, things like that. I had radiotherapy on my knee, things like that. It did no damn good at all. Complete waste of time. Thankfully, things have moved on, but I don't actually see any clinicians except for my own GP, who thankfully is excellent and interested in pain, which in itself is quite unusual for a GP to actually be interested in chronic pain. So that's fine, and we work very much as a partnership. I tell him as much as he tells me, so it's quite good that way. But no, I'm afraid for my generation, we learned absolutely nothing. We were just given pills. I think I've been through every medication known to man in my life. In fact, I was treated for an inflammatory disease for about 25 years, I think. And then suddenly they discovered, oh, no, it's not that at all. It's neuropathic. So,
I think it unfortunately hasn't progressed as much as we hoped that it would. So like I say, I'm now about 11 and a half years into my pain journey. it was about 6 years before I ever had anything, any discussion about self-management. And because, like I say, we're living in this paternalistic kind of healthcare system, I was expecting to have things done for me. And that was very much the, okay, well, we're going to try this drug. Okay, well, we're going to send you to physio. Okay, we're going to do X, Y, Z. But there was no discussion about what I could be doing in the meantime. So I might be put on amitriptyline, for example, and think, okay, the pain's better, but I'm not really as compos mentis. It's kind of very brain fog provoking. But no one was ever telling me, okay, well, here's what you could do maybe in combination with that treatment. Here's what you can do in between appointments to take care of your own health. Now, I've been incredibly lucky. I doubt she'll ever listen to it, but I'll name drop Dr. Rachel Gorodkin at the Manchester Royal Infirmary. She was still is a wonderful rheumatologist, and she was someone who just took huge amounts of time to just sit and discuss with me and to give me the time to ask all the questions that I've been waiting for. I was very fortunate with her to have an hour-long appointment, but you don't get that usually. So I think it's telling people early in their journey, even if you've only got 10 minutes, telling them about self-management, because they might not want to hear it at first. They might think, oh, well, you should be giving me the silver bullet, the magic pill. But over time, it will get into their heads and they'll recognize that they have a role in their own healthcare. And every clinician that I've dealt with who's focused on self-management has always given me kind of better results, not necessarily just in terms of my pain, but predominantly in quality of life. My functionality is much better now than it was the last time that we spoke in 2020. And that's because I've been implementing better self-management practices that have been informed by clinicians who are really on the pulse with pain management, as opposed to people sending me for more drugs, sending me for injections, etc.
Mm-hmm. I've also improved since the last time we did one of these webinars. It's purely through the social prescribing scheme and what we've been working towards with that, because it's forced me in a way to get out of my house and actually meet with people. It's had me on my knees at times and the stress has been incredible, but by God, I've thoroughly enjoyed it. I've come home from art therapy sessions and that quite buzzing. Just because I'm meeting people face to face and interacting with them, because I've had so many years pretty much stuck indoors with my cat, as you saw earlier before everyone came on board. It was me and him throughout the day, and that was that. But now I know people face to face. As Joe's saying, they're not just names now on a list, they're actual people. So the social aspect is huge.
Mm-hmm. Mm-hmm. It sounds like I guess when we're discussing about what type of information should be delivered to patients, especially going through everybody who's trained as a clinician, you've gone through the process of degrees and all this kind of thing, and usually they train the ability to correctly figure out the diagnosis, figure out what the issue is, when actually you've mentioned a few bits there about it's probably more of the soft skills. Maybe we need to pay more attention to communication and giving people, you've both given great examples there of effective forms of education that you received in it, and there was nothing to do with getting the right answer or the diagnostic tools. It was more about just providing time and listening and that reflective discussion. Do you feel like that's potentially not necessarily more important, but maybe they need to focus on that a little bit more as clinicians?
Yeah, I mean, the example that I would give, there was a really beautiful paper from back in 2021 looking at health economics in fibromyalgia patients. And it was looking at patients who met some of the NHS criteria for diagnosing fibromyalgia, and those that were diagnosed had greater healthcare utilization and worse outcomes than those that weren't. Now, okay, possibly controversial for some people. It's hard to know whether there's benefit of giving a diagnosis in a condition like that, because there's likely not an obvious biological reversible cause. But giving them the diagnosis wouldn't have changed anything. That hasn't actually improved their quality of life. Focusing on that biological element, obviously biological plays a large part of biopsychosocial. I'm not going to say let's ignore it and pretend everyone's fine. There are underlying causes in a lot of people. Some people gain a lot of benefit from biological treatment modalities. But yeah, the soft skills are the things that are easier for the clinicians to learn as well. It's not hard for a clinician to learn how to refer you to a social prescribing scheme. They're all over the country. They're not, we're the only one currently specifically dedicated to pain, but people with pain can be referred. It's not hard to learn about what activities are maybe suitable in that scheme for people with chronic pain and say, hey, why don't you go and join this walking group? Or there's a hydrotherapy session, or did you know that there's a book club? Did you know there's a board game meeting, etc., etc.? Like getting people out in the community, and the psychological element, the pitfall that a lot of clinicians fall into when trying to educate patients is the term "all in your head." Now, everyone listening to this knows that pain is all in your head. That is where we process pain. That's what differentiates nociception and pain. But if we don't clarify that we mean that the brain processes the pain, it's the processing of the pain that's in the head, not you're making it up. And trying to contextualize how psychology might be involved in pain so people don't feel offended by it. The example that I always give is if you stub your toe and I hand you a lottery ticket that's won 10 million, you're going to feel a lot better than if you stub your toe and then I throw a drink over you. The negative element of that sort of psychological experience worsens your pain experience, and it doesn't invalidate your pain experience at all, but just showing people relatable examples rather than the message getting misconstrued and patients thinking, oh, I don't want to see them again, they said the pain's in my head. Those soft skills are really easy to transmit to patients if you just come up with a couple of stock examples. And the good thing is it's so low level, it doesn't need to be personalized yet. It doesn't need to be, okay, here's an example specifically for fibromyalgia. We're all living with pain, and these are just getting us to start processing how our pain is linked to our social life, how our pain is linked to our psychology. So yeah, I think it's far more important. Obviously, they still need to be looking for diagnoses that might be harmful, but the educational aspect of an appointment should be focused on that psycho and social side of it.
Mm-hmm. Mm-hmm.
If patients aren't particularly interested in pain gateways or the role of nociceptors and things like this, they would just glaze over when they're told these sort of things. All they're interested in is, how on earth am I going to live with this? And clinicians need to be honest as well. I've had many people say, "Oh, but yeah, you can cure chronic pain." Well, no, you can't. I mean, let's be honest. You can throw everything at it, but sometimes, to myself, I sometimes think it's like a sentient monster that's living inside you. It fights back when you try and get it under control. It seems to fight back. So you've got to be honest with patients. And say, well, you could have this for the rest of your life, but this is how you cope with it. And we can't cure it, but we can make it more livable. And a pet hate of mine is this current, I think Joe knows what I'm going to say, but there's this current obsession with banning opioids and saying, you're bad, you can't get them. Goodness, no, they do help people. I wouldn't be alive without mine. But we seem to have, well, for a few years now, we've went along the line of opiates are bad, so we can't possibly give them to people. But then you're leaving people in so much pain that they're attempting suicide. Thankfully, there are papers and things coming out now saying how the FDA and CDC got it all wrong in 2016. And, things are moving that way. But of course, we're all different. I mean, in some cases, opiates are not the answer, and they certainly shouldn't be used first off, but there is a need for them. And, I find these days, I can only speak for my own country, but it seems to be that politicians, NHS boards go for a blanket approach with policies. They do not treat people as individuals. It says in government literature and everything, we operate a person-centric approach. Absolute rubbish. They do not at all. When you actually get into the clinician's office, I think most members who have been to a pain clinic get back in touch and say, oh, they stopped all my pills, what am I going to do? That's terrible. There's no person-centric approach there at all.
Mm-hmm. Mm-hmm. And, I think one of the suggestions perhaps why we don't do that is because it's not easy. We can't say here, and providing that is an easy thing to do. We know that we have to do it, and we're going to have things to help clinicians be able to provide that patient-centered care. Just a reminder to the viewers who are here, anyone who's here, you can ask questions. You can use the Q&A function down the bottom. You can also do that anonymously if you feel like you have a question that you want to provide anonymously. Just a reminder to get those in, and we can get those answered before the end of the session. That would be fantastic. So just kind of touching on a little bit what you guys have covered there, which is really, really useful stuff. I've heard a few times, and you might be able to reiterate this, is one of the soft skills that you've mentioned or hasn't been mentioned is just simply believing that the person who is telling you what they're telling you. And I guess it's another thing that's easier said than done. We know how subjective the pain experience can be and how complex it can be. But were there any instances where you felt like, or is this common to other people with chronic pain, that they don't feel like they're being believed? And should that be something that's easy for clinicians to be able to do in clinical practice, just simply believe them? And what effect does that have on your management?
I mean, there's a paper by Jeremy Gauntlet-Gilbert. He looked at the opinions of emergency department staff on individuals presenting in A&E with chronic pain, and the quotes are absolutely shocking, and the very frequent use of the word malingerer, and that's still an opinion that is really, really prevalent across healthcare professionals. I think hopefully becoming less so now, but there have definitely been several times where I felt that I wasn't believed. I know that I presented in A&E at one point about 4 years ago, because I went to see my GP and they said, there's nowhere else we can send you today because it was a bank holiday. They said, A&E is your only option because they might need to take you as an inpatient. And during the triage, I had a nurse say, you shouldn't be here. There's nothing wrong with you. Like, we've given you all the scans that you want, and et cetera, et cetera. And I mean, by this point, I'd really moved towards self-management. So I hadn't seen a healthcare professional in the best part of a year. I'd been really trying to stay away from wasting the healthcare system's time. But yeah, absolute lack of belief. And when you have that lack of belief, there's only so many times you can have someone not believe you before you start to disbelieve yourself. And you think, well, is it all in my head? Am I going crazy? And when you combine that with the prevalence of mental health conditions in people with chronic pain, when you look at the prevalence of depression and anxiety, when people don't validate that experience that you're having, it just piles more weight on top of everything else. It just makes you feel more like you're making it up. And when you feel like you're making it up and you're not getting this information about self-management, you kind of just end up in a bit of a hole where there's nothing that's really helping you. The pain feels really unbearable, but you don't even know if it's real at that point. You've been kind of talked out of believing that your experience is genuine. And I can understand why there's been this hesitancy to believe people with chronic pain back when drugs were the only option, or at least the only option that was ever given. If it was a choice between believe them and put them on gabapentin straight away, or disbelieve them and send them out your office, I can understand why you wouldn't want to put people through those long-term effects of the healthcare. I know that Chris was on pregabalin, and it took away years of his life because he was a shell of himself, and it was similar for me with duloxetine. But now that drugs don't have to be that first option, you can encourage people to explore self-management. There is no negative to validating their experience.
I'm relatively lucky in that I now need to walk with 2 walking sticks or 2 crutches, so I look sore. But in my youth, and I did have one, I look perfectly healthy from the outside. And I was just not believed. I've been called malingerer and worse names many at a time. And it is devastating. absolutely devastating to you when you are in so much incredible pain, and you just, you know, I have been driven to near suicide a couple of times because of that. There just didn't seem any way out of it, and people just weren't believing. You thought, well, why bother? You know, why on earth should I bother fighting this all the time? People don't believe me. I think if a clinician, the first words out of a clinician's mouth when you go into a room should be, I absolutely believe you're in pain. That would be wonderful for a patient to hear. It would really set them at their ease. Okay, they may want to look at the specifics of it, what type of pain it is and things like that, but you must say to the patient, I absolutely believe you. Of course you're in pain. If I can plug our website for a minute, www.afasair.org, you'll find in there lots of different articles and things. But there's a poem I wrote called Invisible Pain Revealed. Have a read of that. That really tells you what it's like to be in chronic pain. And it goes back to this thing about it being invisible. If I was to glow red or blue or things, you know, when I'm sore, I would get a lot more. It's not really sympathy I'm looking for, empathy. You know, people would understand when they could actually see under the skin, but they can't, of course. You know, and you can't blame people to some extent. Even in families, you'll find that people just don't believe you, and that is very, very hurtful. You know, it really is terrible.
Mm-hmm. Mm-hmm. It's you know, horrible to hear, but these things happen, and it almost seems like a very simple solution, especially initially when they enter the clinic. I believe you, you know, and that will straight away. And I think a lot of clinicians will agree that is something that is a very, very easy thing that they can pick up and use straight away in clinic, which will have profound impact. The link has just been posted in the chat, guys, for the efisair.org. So go and have a look at the online resources there that Chris was talking about. I just want to, Joe, I'd love to ask you a question from the online information, the online videos that hopefully everybody has seen. If not, please go and check that out on the EFIC Academy platform. It kind of goes into your advocacy work that you mentioned in the talk. I don't know if you could follow up on that. You mentioned some really interesting work about sort of going to universities and medical schools and talking to them about the patient experience specifically. Could you give us a bit of an update about that and how that's gone?
Yeah, so this work came from a review of all of the publicly available medical curricula, curriculums, one of them, available in the UK. So there's only 9 medical schools that speak about a compulsory pain management section of their medical degrees. The physiotherapy courses tend to be a bit better. Nurses, acute pain management tends to be very good, but they don't get a great deal on chronic pain. So I reached out to these medical schools and had a underwhelming response, extremely underwhelming. What was most frustrating was that a couple of the universities who did decide to respond for a discussion, one in particular, which is one of my previous universities, so I won't say which one, said, and this was a university that I was attending at the time, so that's a clue for you. They said, "Oh, I'm sorry, Mr. Parsons, we don't have any interest really in engaging with you to provide this lived experience or any pain education because our students get more than enough." So I went digging more deeply into their syllabus and had a friend who was studying there on the medical degree and looked at the full non-publicly available syllabus. They have 1 2-hour lecture about pain management, both acute and chronic, in 7 years. So 5 years of uni, F1, F2, 2 hours. And that is deemed to be more than sufficient. So this is why that I've had a change of tack over the past couple of years and trying to look now at communicating to patients via efisair, because I feel that they're the most important people to hit, and looking into alternative ways to reach people. So looking into podcast media, looking into becoming a part of clinical networks. So things like the Physiotherapist Pain Association, and then starting to disseminate information that way. And I'm not going to lie, that is an element of why I'm retraining as a physio, is because it seems impossible to change from the outside. So get yourself stuck in and be in that clinical setting where you can be respected. Funnily enough, since finishing the PhD, I'm not a medical doctor. I'm a doctor of biochemistry, but the respect that I receive from clinicians now when having these discussions is infinitely higher having that title in front of your name. When you're just someone with lived experience, really, then they're trying to say, oh, well, our syllabus is fine, our curriculum's fine, see you later. But having doctor in front of it makes you a lot more respected by these individuals in these universities. So we are still knocking on doors and chasing people. But yeah, it surprised me, but the universities have been very unwilling to engage in sort of further pain training. And sorry to go on for so long. It's not just myself who's offering to go in. So I've got a lot of friends who work in pain management. So I've got a very close friend who works in NHS Highland who was offered to go in and do the lectures herself. Now she was offered to run the pain clinic. She rejected it because of family reasons, to have enough time with her kids. But this is someone who is very senior pain management staff who they decided, no, we won't take a free lecture from an expert in pain management. We're not asking them for a couple of £100 for a lecture fee. We're saying we'll come in and do this for free. And even with that opportunity, there's still a great deal of hesitancy. So yeah, I have to go about it a different way.
Yeah, I was going to say about Joe that, I mean, it was great when Joe came aboard. He brought a heap of youthful energy, which has so long seeped its way out of me, and that was terrific. But when he became Dr. Joe, by goodness, doors suddenly flew open that were just closed to us before, and that's incredible. Joe and I could argue amongst ourselves who's the most knowledgeable on pain, me or him, but that shouldn't matter. But because he's now Dr. Joe, I use him a lot, say, we'll get Dr. Joe Parsons to speak to you, blah, 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 blah. And that opens the doors. Another good thing coming out of the Scottish Government's Chronic Pain Task Force is they are making inroads into all the third sector networks having a specific point of contact in each NHS board. But that's been an aim for, I don't know, 18 months or so now, and we're no further forward. It's a great aim, but we need more than words. We actually need that in place. We need someone that we can go to in an NHS board. Perhaps for your European colleagues, that's the way the NHS is provided in Scotland and in England, that each region has its own board, so they don't all work as one, they're all separate. But if the third sector networks, i.e. charities, had someone they could go to and approach, then that would help. But no, we don't. I know some people now in one or two of the boards, but that's it. There's no official contact. Mm-hmm. So a lot of information and help is lost.
Yeah, absolutely. And it's I guess it's an issue that's going to be persisting for a while. We just need to make sure that we take the steps to address that. And it's not an easy one, but I think recognizing it, and certainly you mentioned there, Joe, about the education that's been delivered, 16 hours, and there's varying consensus around that, but generally we know that it's not enough, what it should be. And I would perhaps question, as part of those 2 hours that's been included of pain education within the curriculum, how much of the patient perspective is being included in that. I think it would be, off the top of my head, and the stuff that we've delivered and we've seen delivered is very much evidence-based, and very little patient perspective, and the importance of a collaborative approach to self-management and these types of things. Do you think that that's something that needs to be addressed at the education, the curricular level, providing patient perspectives and lived experience, and the importance of that in managing chronic pain?
Yeah, I mean, take GPs, for example. You've got nearly 30% of a GP's appointments are due to chronic low back pain. And if they're not being trained on how to manage this properly in their degrees, putting the onus on GPs who are already overstretched, and the same with any healthcare professional, putting the onus on a nurse or a physio or an occupational therapist or a psychologist, the NHS is so unbelievably strained that asking them to take on extra training is just unfeasible. I know that they have to do continued professional development training, but there's only so much you can fit into there. And if you are working in a hospital, for example, there's a lot of different types of training that you would need depending on which patients you see most commonly, and pain might not be your priority. So taking it at that early undergraduate level where it's unavoidable, forcing these students to learn about it, and looking at it in OSPEs, so the practical exams for medics, for physios, for nurses, giving them situations where there is not an obvious condition and where we're not expecting you to diagnose it. We're expecting you to handle this initial appointment with the patient and give them the appropriate diagnostic testing as needed, but giving them the appropriate tools to manage their health until the results of the scan are back or until the next time they see you. Because if you give people the choice of whether or not they're going to learn it, they're so stretched that the choice is going to be that they're not going to learn it. So having it earlier on in the healthcare system, the Canadians and New Zealanders do the best in terms of pain education. They get 20 hours of mandatory training. If we could even hit that kind of 1.5 times what we have now, and topping it up with bits of patient perspective, lived experience, even if it's just one sort of 2-hour lecture with some lived experience individuals, a standardized lecture that's done all over the country, I think that would make a world of difference.
I think I hate to give us more work, but if anyone listening to this wants to hear the patient perspective, then here we are. Get in touch. We'll do it. That's fine. I think it's important for us to pass the word round and things. And I do wonder, I don't know how you think about this, Joe, but I wonder if the problem is maybe more NHS managers than clinicians. The managers have to keep their eyes on budgets and things like this. And, I can imagine them saying, well, why do we want to hear from uneducated people? No, we don't want to do that, So I think we need to make inroads there to get to the NHS managers. I should say, and not to keep promoting the Scottish Government, but I'm actually speaking to the Paying Clinicians Network in Glasgow on Wednesday. That's a huge improvement that they're willing to listen to a pain patient. That's great news. So we are making some progress, but it is slow.
Mm-hmm. Yeah.
Amazing, absolutely amazing. I love these stories coming through, and I guess if anything, it's not necessarily making an hierarchy of the importance. Is a biological assessment more important than hearing a patient's perspective? I think it's recognizing its significance in curricula and in clinical practice. Just to kind of round up, we've been going for nearly an hour now, and I'm sure we could go on for another 2 or 3 with this one. But in your opinion, obviously, as people with lived experience of pain, what are your sort of key points about education surrounding pain? What are the most important things that clinicians should focus on?
For me, belief is the most important thing, but they need to look at the person holistically, not just the pain, but very much the mental aspects too, because and the fatigue. Sometimes fatigue is even worse than the pain, and as I say, be properly person-centric, please. That would be my one wish.
Mm-hmm.
Yeah, and for me personally, I think the belief is obviously a really important element, but just learn about where you can signpost. So even if you don't know the appropriate self-management tools for that patient, have somewhere where you can direct them, even if that's to us as AFSA, say, here, join this group. You live in the north of Scotland, come join this group. We can give you advice, they can give you guidance, they can point you in the right directions, whether it's recommending people go to social prescribing activities, whatever it is that they're doing, or if it's getting financial support, if the clinician recognizes that to be a major stressor that might be elevating the pain. So knowing those appropriate signposts and being able to get them across very concisely, if that's giving a printout to the patient, if that's just saying, okay, I'll email it you afterwards, just making sure they can get that information across without taking up too much of the appointment itself, because their time's already stretched. Because even if that's a stock printout that they give to everyone who comes in with chronic pain, it's better that they transmit that information somehow than not transmit it at all.
Mm-hmm, mm-hmm. And you've mentioned some of these online platforms, these online resources, and perhaps assessing an individual's sort of literacy in being able to access those types of things. You've mentioned before platforms such as TikTok, and the information is going to be variable on any form of delivery. And I guess recognizing which one is most suitable for them to support self-management. Not necessarily the quality, but obviously we need adequate quality, but also providing something that's suitable for them and fits in with their hobbies and how they take information.
Exactly. I mean, if you got someone who maybe has a lower level of health literacy, resources like Tame the Beast, Laura Mosley and David Butler's website, it's just fantastic. It's such a brilliant introduction at a low level. If someone's a little bit more versed in pain science and more interested in that pain experience, you might look at Airing Pain, the podcast by Pain Concern. There are, as you say, there's levels to it, and you've got to find the appropriate one, but there's resources for all those levels. So if the clinician, like you say, could wrap that out during the appointment and work out what level to deliver this information, they could give the appropriate signposting.
I had, again, at that art therapy session last week, I had one of our members tell me she was being referred to the pain clinic for the first time, and she was petrified. She is neurodivergent, aren't we all these days, though, myself included, but, she's absolutely terrified, and she doesn't articulate well, but she's a lovely person. So, I pointed at her to, again, one of the resources we have is a pain questionnaire that I try and get people to fill in before they go to the pain clinician, because she, as she was saying, she gets so tongue-tied when she sees a clinician in front of her. She forgets what she was wanting to ask anyway. She gets, because she has autistic type problems, she can't always get the words out. Hey, and she found that questionnaire really helpful, because she could sit at home and tick off the words and things describing how the pain is. These sort of things would help people. And I know in the past, these things have been given out, but they're usually poorly photocopied scrap bits of paper. And they don't look as if the patient is going to be taken seriously by the quality they're given. So, perhaps, clinicians, send out these things to your patients when you're giving them appointments and things, and get them to fill them in beforehand in the comfort of their own home. So you can get that initial, I mean, that must save, 15 minutes of an appointment time, surely.
Mm-hmm. Mm-hmm. And obviously that's more time spent.
Yeah.
Time is a big factor in providing that support. Yeah, for sure. Thank you, guys. I really appreciate your time today. We're going to have to end there. Again, thank you for taking time to spend and discuss these things and tell us more about what you get up to. I think we've covered some really interesting things. Like I say, we could go on forever. As I mentioned earlier, the webinar has been recorded, so everyone can access this on the online platforms of EFIC and on the YouTube. It's usually on there as well. The original talks that we kind of referenced as well from 2020 are also on there, so please take a chance to go and have a look at those. And there's obviously the link to the FSA resources, online stuff in the chat as well, and it's in the email. So there's lots of different ways, as we mentioned, lots of different ways to access this information, which is great. So yeah, thank you so much for your time. To everybody who's attended the session live, thank you so much. I really appreciate it. And yeah, have a fantastic rest of your day.
Thank you.
Thanks very much.
Guys.
Take care.
Bye.